Huge unmet need here for these patients. Up until, in the US, up until last fall, September, I believe, that there weren't any approved therapies for these patients. And so essentially when they got the diagnosis, it was like a death sentence. Now we have therapies. We are very excited that Esbriet, pirfenidone, has been approved and is available to patients with the disease. And we really want to make sure that patients who have this disease can get the therapy that they need as quickly and as expeditiously as possible. As you know, idiopathic pulmonary fibrosis means that patients develop fibrosis or scarring in their lungs, and we don't know what the cause of it is. It's idiopathic. And pirfenidone, Esbriet, has an anti-fibrotic effect. And so what pirfenidone does is it prevents the formation of new fibrosis, and that is what leads to deterioration in lung function over time that ultimately causes patients to die. So if you can prevent fibrosis from newly occurring, you can slowly decline the progression to mortality. Esbriet has already been approved in Europe for the last 4 years, and last fall here in the US in 2014, the FDA approved Esbriet, pirfenidone, for the treatment of patients with idiopathic pulmonary fibrosis. Absolutely, absolutely. Although, unfortunately, we always want to ensure that medication that is effective gets to patients as quickly as possible. But the benefit of pirfenidone already having been on the market in Europe for 3 years before it was approved here in the US does give us a high level of confidence about the safety of the product and how it can be safely used once it gets approved. And that is the benefit of something that's already been approved elsewhere for 3 years before it comes into the approval in the US. So the phase 3 data showed a couple of things. Number one, it does reduce the decline in lung function. And that's really critical because it's the reduction in lung function. And we measured FVC, forced vital capacity. So if you can reduce the decline in lung function, patients presumably can live longer. So we've been able to show that in our clinical studies. We did a pooled analysis of our phase 3 studies to show that Esbriet did have a beneficial effect on mortality. And we've done some additional analyses on our phase 3 program since the product was approved. And a couple of things. We found that in patients that were treated with pirfenidone, who had a 10% decline in their FVC after 6 months. And we compared that to a similar population on placebo. So patients on placebo that also had a 10% decline in FVC in the first 6 months. When we followed them for the second 6 months, the patients on Esbriet still did better than the patients on placebo. So what that suggests is that even if you see a 10% decline in FVC in the first 6 months of treatment while you're on Esbriet, don't stop the medication, because these patients are still going to do better than patients that were not treated with the medication. So that's the first thing. We did another analysis on our phase 3 database that showed that patients that were hospitalized in the first 6 months for their IPF, the patients that were on Esbriet versus the patients on placebo, in the second 6 months, the patients on Esbriet still did better than the patients on placebo. And so it's a similar conclusion from the other data we analyzed, that if a patient has a 10% decline in their FVC in the first 6 months or they get hospitalized, don't stop the medication because they're still going to do better than patients that are not receiving anything. The bottom line is what we're trying to do is slow down the reduction in lung function. We're not going to reverse it or cure it with pirfenidone, Esbriet. And so even if there's evidence of decline, it doesn't mean that they're not responding to the medication. Ofev and Esbriet work by different mechanisms. We're presuming that pirfenidone works through an antifibrotic mechanism, whereas Ofev is a tyrosine kinase inhibitor. So they get at the same thing through different mechanisms. There are patients in IPF that present very differently. So we know IPF is a very heterogeneous disease, and some patients decline rapidly, some decline very slowly, some decline quickly, then slow down, then speed up again. Nobody really knows if one drug over the other has a benefit in perhaps some of these subpopulations.